All right. Hi, everyone. Welcome. Let's see. I see people are still coming into the room. So we're so glad that you could be here with us. See, welcome to Mini Med, session 3. We're blazing right through our 6-part series, just about halfway there. So looking good, feeling good. We're glad you could make it back again. I know there are a lot of things happening and you're probably very busy. So thanks for taking the time. We appreciate it. So just wanted to give a little info and intro before we get started. So yeah, just wanted to talk about UCSF Fresno. Again, we love it. It's the largest physician training program between Sacramento and Los Angeles. We're very proud. So thanks for joining us for the 3rd session. And yeah, let's talk about our pal, our favorite doctor, Dr. Dillon, the program director. She's wonderful. So let's give you the rundown. Those of you that have been here before know a little bit, but I throw in a little extra, just to keep Dr. Dillon on her toes. So Dr. Suki Dillon, Dr. Dillon is a Fresno native who went to Fresno State, go Bulldogs, for her undergraduate education. She earned her medical degree at Chicago Medical School and completed her emergency medicine residency training here at UCSF Fresno. But did you know, during this time, Dr. Dillon was selected to receive the Robert Knopp Gold Humanism Award and the Melissa Dowd Community Service Award for the Department of Emergency Medicine. So she received those upon the completion of her residency. So she's wonderful. The department knows it. Everyone knows it. She gets awards, so you can trust what she says. She currently works as an emergency medicine faculty here at UCSF Fresno and has been working at the Department of Public Health since February to contribute to various guidelines and protocols in response to COVID-19 here in Fresno County. So please welcome Dr. Suki Dillon.
Thank you, Summer. Where did you find those awards?
Well, I have my way.
Hello, everybody. We have 2 great speakers with us today. But before I introduce Dr. Simpson, I am going to do one poll question real quick with you guys, and then I'll introduce Dr. Simpson and we'll get started. Hopefully everybody's having a good evening. Let's do this. We're going to talk about books today. What is the most recent book you've read? And you know how to respond. Educator was a good one. I read that. That's it? That's all the books you guys have read? Here you go. Harry Potter, perfect. My brother is crazy about Harry Potter. I actually never got into it. There's some books that I actually haven't even heard of yet. So I like those. Wow, nice. Awesome. I see Harry Potter and Educated and Republic is right on top. Perfect. Love it. Well, I'll save these so I can read more for sure, because I for sure have to do that. Well, welcome everybody. I'm gonna stop sharing. Thank you for participating into this poll. So I'm gonna stop sharing my screen real quick and I'll introduce Dr. Simpson and then we'll get started on our first talk. So if you joined us last year, so you know Dr. Simpson then, I'm sure he's been with us multiple times. That's when I worked with him last year. So Dr. Simpson earned his medical degree from University of Tennessee and then completed a prelim internal medicine year at Georgetown University and then finished his dermatology residency at Medical College of Georgia. He has been the medical director at UCSF Fresno Dermatology Department since 2013. So a long time. That's awesome. I want to know how long you've been with us before that, Dr. Simpson. Did you come here in 2013 or before that? All right, 2010. Okay, awesome. His interests are complex pediatric and adult dermatology. So basically any sort of inflammatory derm diseases, especially blistering disorders, which there's a lot of, and sort of inpatient condition that people get admitted for with derm conditions that patients are admitted for. So that's awesome. He's won multiple teaching awards. I can for sure tell you that he's a great teacher. I worked with him in his clinic, and that was awesome. He does like to pimp you, so he does ask lots of questions, so he keeps you on your toes for sure. Yes. And he has won an Attending of the Year award in 2017, and he's lectured at various different places, including DC, San Francisco, Georgia, within the last 2 years, which is awesome. Some interesting facts about him. He and his wife was a Fresno native, and they have 3 kids. And I believe they love Fresno. That's why they're stuck around this long. And they enjoy outdoor activities, which is awesome. And because of where he has lived during his lifetime, he's actually been exposed to the 3 main fungus that we always worry about in medicine. We can talk about it later: the histoplasmosis, blastomycosis, and coccidomycosis, which is what causes the valley fever here in the valley. So that's pretty amazing that you've been exposed to all 3 of them. He also owns his clinic is the only clinic where you'll see doctors from all different specialties being patients there, and also working there at the same time together. So that's pretty awesome. And I'm gonna let him take over the talk and share his screen and go from there.
Okay, we ready? Okay, that was the nicest introduction I've ever gotten in my life. Thank you very much, Dr. Dillon, and thank you, Summer, for putting this together. Just to go ahead and get out of the way, it is not my birthday today. I've left that happy birthday sign up there for many years. It's just every day is a holiday, so it's always my birthday. All right, good. So let's get going here. So I have no conflicts of interest. Derm is very off-label, so I'm not going to talk about off-label, and there's going to be some graphic photos. Okay, first poll question. How many mini med schools have you been to? So there's been, I believe, 9, and I think I've done this at 7 of them. So there may be some throwbacks today to ones that I've done in the past, but that's just okay. Hopefully you'll just be reminded of something awesome I said in the past. Okay, do I have to click anything to make it pop up? Show responses. Okay.
A lot of people are responding in the chat.
Spin in the chat? Okay.
Yeah, I can tell you about them.
Okay, that's okay. Doesn't matter. We'll keep going.
Yes. So a lot of people, it's their first. There's one who's done.
Okay, there we go. That's pretty good.
There we go. Yep.
Okay. All right. On we go. Okay, so what are we going to talk about? So I've talked, surprisingly, last year, I talked about pandemics. I'd almost forgotten that I did that until I was looking back, and I thought, this is pretty funny to be talking about it before we have our own personal pandemic. But I'm going to approach it from a different angle right now and see, all right, what did those people do when the pandemic came? I'm going to talk a little bit about the stuff that I'm seeing right now: COVID rashes, eczema, and maskne, and then a little bit about cutaneous issues and skin of color. Okay, here we go. So this right here, this would be considered necrosis, necrotic, or dead, basically a dead hand. And these are lymph nodes that are swollen in the neck. If you saw these for long enough, they would do the same thing. They'd burst, they'd turn black, they'd do all this sort of stuff. So this is an example of the plague, or the Black Death. This is generally carried by these cute, cuddly little squirrels and mice. And this is the little flea that goes along them. Okay, so what are they? It's caused by Yersinia pestis, which is a gram-negative coccobacillus. The main things we have are cocci, which are like spheres, and bacillus, which are like rods. And this is our little thing up in the right-hand corner there. It's sort of in between. And the gram is a type of stain. It's by this Danish doctor, Dr. Gram. And basically the gram-positive ones have bigger cell walls that are half protein, half carbohydrate, but they take this stain better. It's a good way to split bacteria out into 2 categories. In general, gram-negatives can be a little bit more problematic because they're a little sneakier. But that's when we're starting with bacteria, we go, all right, it's gram-positive or gram-negative. So that's where you start. Okay, so the Black Death hit in the 14th century. This is what we're going to look at. The plague hit San Francisco, and this is basically the first time it hit the United States in 1900. It hit Yosemite in 2015 with 2 cases, and then Lake Tahoe, South Lake Tahoe earlier this year, 1 case. It's about 7 per year in the United States. The biggest outbreak in the last recently was in Madagascar in 2017, and 200 people died. Okay, so how did the Black Death go? Well, it was starting around in China. It banged around there for about 30 years. Then it sort of traveled the Silk Road, this old school trade route from village to village to village. Then it got over to the Black Sea. It got on ships and then started hitting Europe. Now, the Black Death, we have, 200,000 deaths here in the United States right now. Well, the Black Death killed almost 50% or more of Europe's population at the time. Overall, the world had 450 million people then, and it got reduced by probably 100 million people. What's interesting is you can see this in the carbon dioxide dating for the next 200 years. It goes down because you lose, a fourth of your population. Trees go back and all this sort of stuff. So anyway, how did they deal with it when the plague came? Okay. When it came to Venice, Italy, there was 18 men that were registered as plague doctors. These were the educated doctors. So what were they going to do when it came? Well, 12 of them fled. They just said, oh, it's coming here, I'm out of here. And they just totally bailed. 5 of them that stayed died. So the point was there was nothing that anyone could do. So this led to really a lot of distrust of the medical world. And this sort of very popular historical book, Jean Froissart, I looked up how to pronounce his name, Chronicles. It was a book that sort of looked at 1300s, back when a war between England and France and all these sorts of things. It basically said doctors had to lie, not get caught, pretend to be honest, and cause death without guilt. And the reason was the doctors, the people who knew what was going on, they all bailed. They were all gone. So the people that are left to be doctors were kind of charlatans and basically people who would sell you, fake medicines and then watch you die and then move on to the next one. So there was not a lot of trust of the doctors. Now, this is the plague outfit we think about, but that didn't come up till 1619. So really, when the real Black Death hit, that wasn't around, but we kind of have squished the two together, and that's the plague outfit we think. Okay, once they were there, what did they try to do? Treatment. Well, leeches have been very popular throughout history. There's kind of 4 humors historically. It is blood, black bile, yellow bile, and phlegm. So we try an angle for each one of them. So you cover people in leeches. If anybody's ever had a leech on them, it's not comfortable. What it looks like is you're on some gross pond and you look down and there's a leaf on you and you try to rub the leaf off, but it won't fall off. So there's not a lot of leeches in California, but there certainly are in Tennessee and North Carolina. So leeches, but this didn't work. You just hope to get rid of some of the bad blood, but it didn't work. Next, they try arsenic and mercury, which is poisoning people. That didn't work either. Otherwise, another plan was sitting close to a fire, which you basically cook yourself and try to cook the bad humors out. That didn't work either. And also we'd whip themselves. This was more of a religious thing. People would go to random towns and whip themselves. That didn't work either. Now, what actually did sort of work? Prevention. Okay, so if anybody's been to Dubrovnik here, it's right across from Italy and Croatia. This was the first place they started to kind of figure this out. So Dubrovnik was a big shipping port, and what would happen was ships would come to town and they'd stop them and say, nope, we got to make you sit there for 30 days. You're in isolation for 30 days. This is called a Trentino. And then for religious purposes, like, the 40 days flood with Noah and the 40 years in the desert, for religious reasons, they made it 40 days. So now it's a quarantina. So this is the historical reason for the quarantine. 40 days, you'd sit on your ship and make sure that you weren't sick. Now, this plague went fast enough that usually you'd see if someone got it in that amount of time. And that was one of the first ways you could prevent this from coming to your place. Although, what they didn't know at the time was it was on fleas that were on rats. So a lot of times the rats would get off the boat. But if they made them quarantine off in the water, in the bay, they'd be okay. In Dubrovnik, they also made isolated hospitals, which was good. Okay, so when did the plague actually come to the United States? So it was in 84, 85, it was in China, then 89 or 99, it came to Honolulu. So it came into Chinatown in Honolulu, and they were worried about it, so they started burning some houses where people had the plague, and that fire went crazy and burned down all of Chinatown in 99. But then that was not to be deterred, it still made it to San Francisco. Now, how did San Francisco deal with it? Well, there was a huge book, this book by David Randall, a great book, I've read excerpts of it, that talks about this whole thing. So this is a very long story, but I'll hit the highlights. So there was a bit of racism in San Francisco at that point. There was a huge article in the Examiner saying why San Francisco is plague-proof. Well, the Caucasian people thought because they ate so much meat, they were plague-proof. And the Asian people who ate rice, they would get the plague. So this article came out in the Examiner, and what do you know? A month later, they had their first plague death, okay? Now, the doctors around the area, they kind of thought, yeah, plague is coming. I'm going to be ready for it. So this gentleman, Dr. Kenyon, he thought this was plague, and he took the samples to Angel Island. If you guys know Angel Island, it's right next to Alcatraz in the San Francisco Bay. It has a lot of history for immigration. It was military, did a lot of medical stuff there. But that night, he identified plague in this patient. And basically the next day, they quarantined Chinatown. They had ropes and policemen all surrounding Chinatown, but they let the Caucasian people go in and out, but they kept the Chinese people in there. Of course, that wasn't going to work. But what happens next? Well, the California governor, he doesn't like this. He says it's bad for business because if your port has plague, then all of your exports, we can't take them anymore. So the Henry Gage says, nope, no, I don't believe you, doctor. And he calls it the plague fake, okay? So then he starts this massive campaign against this doctor and the doctor's other people in the lab saying they planted the plague on the patient and all this sort of stuff. So this kind of went back and forth for a little while. They didn't necessarily get it under control, but people started to figure out like, oh, maybe this is real. But the Henry Gage did scare Dr. Kenyon out of town, but then Gage ended up losing the next election. So then one thing they did that was pretty bad was they did do forced vaccinations. Surprisingly, it was a Russian vaccination that they got. And Dr. Kenyon, while he was a smart guy, he went and he started vaccinating thousands of Chinese people. And a lot of people died and had horrible side effects. So the Chinese businessmen at that time took a case. It ended up going to the Supreme Court, and they won on the 14th Amendment of equal rights. So it was actually quite interesting. They couldn't do the vaccinations anymore, but they weren't really working. But anyway, by 1903, people kind of knew, okay, this is real. So the next outbreak, they started cementing in all the basements, and they burned a lot of houses and stuff. They did pretty well. In 1906, there was a huge earthquake and another outbreak. Now, by 1908, they finally eradicated it. By that point, it had made it into the ground squirrel population, and that's probably how it made it to Yosemite today. So that's why when you're hiking around Yosemite, there's all these signs that say, don't play with the squirrels. It's because there's fleas on them, and they can give you the plague. So there you go. All right, next disease. Okay, we have a really sick kid. He has cough, coryza, and conjunctivitis. This, of course, is something we don't hope to see very much, but it's making a comeback. This is measles. It's an RNA virus, spread via respiratory droplets. Just to show you some history behind this, before the vaccine was made, there's probably 7 to 8 million deaths per year worldwide. 2001, almost a million. 2018, only 140,000 deaths, which is still way too many, obviously, for a vaccinatable disease, but that's it. We've just started making a little bit of a comeback in the United States, but I was going to use this to talk about R0. R0 is basically the spreadability of disease. And I'll get back to this. Here's a chart of the last 20 years for measles. So look at that, a couple hundred cases for a while. 14, we had 700, and last year we had 1,300. And anybody who works here at UCSF Fresno and was here, I think it was 3 years ago, a measles case went through the ED, and everybody got 100 emails about it, right? Saying, were you here, blah, blah, blah. And I got to see about 10 inpatient consults for measles when it was eczema or something. But yeah, so excitement with measles. Okay. So R0, this is a term we need to know. R0, it depends on three things. The infectious period, how long when you have it, you can give it to other people. The mode of transmission, how you spread it, and of course, how many people you come into contact with. So this changes for every disease, every person. So it's a very squishy number, but they come up with a range in general for what happens to people. So the important things are, if R0's less than 1, you're only infecting one, it's going away because you're not giving it to more than one person. If it's equal to 1, it kind of bops along. And if it's more than 1, you're giving it to more than 1 people and it will accelerate. Now, the other thing we need to know is herd immunity. And that means what percentage of the community needs to be immune to a disease before it's not going to spread like crazy, okay? And as you can imagine, the higher the R0, the higher your herd immunity needs to be. And I was going to show this through some diseases here. Okay, so look at this, measles. So the reason, this is Dr. Schofield's a pediatrician here, fantastic guy, but he worked during measles outbreaks. And the way he put this was, if anybody with measles came into any floor in the hospital and coughed, then anybody the next 3 hours that came in there would get infected with measles. So that's how infectious, that is the R0 of measles. So this is the reason the vaccine was so important, because it has a lot of problems that can come with measles, long-term issues, encephalitis, et cetera. But that R naught of 12 to 18, that's about as high as anything can get. Now this next group, these are all vaccinable diseases. I did have one of my fellow residents at Georgetown get pertussis during our time because I guess, you know, out of bad luck, her immunity wasn't high enough. But she was out for about a month, but she survived. And then here's some more historical things with smallpox. Now you look at the R naughts, it's slowly going down. So HIV/AIDS. The first time I saw this R naught, you think this is odd. Why would the R naught be that high? Well, the reason is because you are infectious almost for your entire life while you have HIV. So you can be infectious for 5, 10, 15, 20 years. Whereas with measles or one of these other flu symptoms, you're infectious for 5 days or 10 days. So that's the reason the R naught of HIV is higher than you would think it would be. SARS, I'm not gonna talk about the influenza pandemic because my good friend, Dr. Ethan Keitel at Fresno State has been doing a bunch of write-ups on this. So hopefully you guys have seen some of that. Now to look at the other side of things, how do these compare to the herd immunity? So there's measles again. We're getting an R naught of 15 and they're saying a herd immunity of 93%. So this just shows if it's that infectious, you need a bunch of people. And really for measles, we'd rather have 98, 99% herd immunity to really keep it from spreading. Here's just a couple of other things. Now, I'm just gonna say what I've read. The numbers for COVID can be anywhere from R naught of 1.8 to 5.7. It just shows you how squishy these numbers can be depending on where you read. And it seems like with how fast it's spread, it may be on the higher end of things, but that's the R naught. So looking at this table, you'd think we need a herd immunity in the 80s to really be safe here. Okay, and there's SARS. Here is just a picture of historical vaccines and smallpox. That's, you know, one of the first ones actually that it pops up in 1800, but in China back in the Ming Dynasty in 600, they did a version of a smallpox vaccine where you do the cowpox. And people may have heard what Edward Jenner, he did the cowpox, he did it to his kids, etc. And what is cow in Spanish? Vaca, for vaccine. So there's the word for vaccine. It came from the cowpox, acting like the smallpox. One other thing we had was the influenza. It came out in the 60s. Decent. Every year it's attempting to get better. One other one is the varicella. See, this is fun. That's chickenpox. So my generation of people, we all got chickenpox. But I'd imagine the majority of people watching here got the vaccine because it came out FDA approved in 95. So a lot of people wouldn't have gotten it, but that was a delight. You get blisters all over you. And then now we have shingles or zoster and the HPV vaccine. Okay. Here's a quick question. Did you get the flu vaccine last year? See, we all have to get it. We can't go in the hospital. There's a no, 100% no. We're scooting up. You know what I should ask is like, are you gonna get the flu vaccine this year? But, oh well. We got a tight race here. Okay, that seems pretty good. Okay, all right, we'll keep moving. Okay, so my segue is always my kids. So this is, my youngest kid is 6 now, so this is the picture when he's a baby, but they're all masked up. Okay, all right, so COVID rashes. Hopefully at this point, everybody's heard of the COVID toes. These are kind of like, one of the fancy names is pernio or perniosis or chilblains, but it's kind of like frostbite. What probably is happening, and they're not really sure, is the COVID virus is in the blood vessels down there. It's affecting blood flow to the area. There's a lot of inflammation. It's not really like an emboli or a clot, but it causes these sort of painful things. If you see this in kids, a lot of times that means they've already figured out COVID, but these can be painless or they can be painful. Other ways we can see it appear, this is called livido reticularis. These things are blanchable. It kind of shows that your blood flow is a little abnormal there. It's one other look. Now this is probably the most common way that I've seen it, and I've seen it primarily post-COVID. These are hives or urticaria, and the way to think about hives is your immune system is just really mad. Your immune system is kind of like a beehive, and somebody hit it with a bat and all the bees are flying around. So you're getting swelling over here, over here, over here. 1 second you're fine, the next second it's terrible again. And I've seen this multiple times after people have gotten over COVID. So you think of COVID being the one that makes your immune system really mad, okay? a couple of other examples of COVID rashes. This is erythema multiforme. We have our little target rashes here. This is actually a chickenpox-esque breakout. So they've had this documented. And this is redness. This is a version of Kawasaki's disease that you've seen in kids. And here's a picture of of Kawasaki's disease. They have sort of the strawberry tongue, your lips are swollen, your face is swollen, your hands are swollen. A lot of times you have sort of this acral erythema stuff going on, and the kids are sick. I'm sure one of the other pediatricians or PICU doc was talking, so maybe he'll talk about MIS-C. For the most part, kids are doing pretty well, but there's certainly Children's Hospital has had tons of cases of COVID, so we need to be careful. Okay, and we have this thing that's run out of Harvard where any dermatologist in town can report a case if they've seen it. So I put a case or two on there. Anyway, all right, so what am I seeing the most? Hand rashes or eczema. And you know why? Because everybody's washing their hands a ton and using moisturizer, or not using moisturizer, using hand sanitizer and whatnot. So I'm giving you practical advice here. So every time you wash your hands, if you're having hand eczema, try to wash as little as you can and still be safe, but you really need to moisturize after you're done there. We really like the clear and greasy stuff, the Vaselines, Aquaphors, etc., which is nice. If it's getting really bad, you can certainly do cool compresses, and that's where you do warm rags and put them on there, put moisturizer underneath it. It's a good way to sort of jam moisturizer back in there. That's pretty good. Over the counter, you can get hydrocortisone, which is helpful, or you can come to the doctor, get something like triamcinolone cream, clobetasol cream, etc. An anti-itch medicine, Benadryl over the counter. I like it to take it by mouth, not necessarily rub it on there, because a lot of people get allergic to Benadryl, but that can be quite helpful as well. Okay, now you need to watch out for these areas getting infected, because they certainly can get pus bumps and all this sorts of stuff on. Okay, now everybody knows this. This is a picture of the Creek Fire, which is still burning, about 30, 40 miles to our east right here. And with all these fires, it certainly flares up everyone's eczema. So all the hands, I've seen multiple people in the last 3 weeks who are eczema allergy type of people that all of a sudden their skin has gone crazy. So this is the thing, your skin is sort of your mood ring. It's, you're depressed, you're anxious, you're breathing in a bunch of smoke, while your skin a lot of times will reflect that. So everybody's got to be careful with that. Okay, now, what is everybody getting? What is this? Maskne. This is, it's funny because for a lot of physicians, and myself included, I haven't really had acne since I played football back in high school, but I've gotten some since we've been wearing masks, 10 hours a day, and that's a good time. So I'm seeing if I have any advice for people on what to do. Maskne. So for outside, the cotton masks are probably pretty good for that. You just need to make sure and wash them. And really, you need to wash your face before you put it on. It's not a great idea to put a bunch of makeup on and then put your mask on. It's just there and rubs, and it's sort of acne mechanica is other name for it. A lot of times you can get that on the shoulders from working out and whatnot. So make sure, try to keep your face clean and the mask clean. Take it easy on makeup. Really try to streamline your routine. Keep it mellow with soaps. Don't use a lot of fragrances, all that sort of stuff. And, over-the-counter stuff you can use, benzoyl peroxide, salicylic acid. These are all okay. They're pretty irritating, and a version of this Maskne can be kind of like eczema and acne. So really you got to work on moisturizing. It's sort of a fine line there. And you can, if you're having a little rash, and a lot of times people get it, you can use a little hydrocortisone there too. Okay. Have you had problems with Maskne? Let's see. No? Dr. Dillon, you said no earlier. Good for you. Okay, we're about half and half here. Okay, good. Yeah, like I was saying, this is not necessarily like treating straight acne. You gotta be way more careful with it, because in general with acne, we're trying to dry it out. So you gotta be very cognizant of moisturizing as well. Well, I wanted to end it when the yes was winning. I want to taint this poll a little bit. Okay, 50%. All right, let's keep going. Okay, so I'm gonna do a John Madden breakdown here. I asked my mom, who may actually be watching right now, obligatory, hi mom, to give me a picture of me when I was playing football. And this is me as a 6th grader. So let's break this down. Okay, so I'm number 79, which shows I was definitely a lineman, and I'm kicking off there, but I'm toe bashing it. This is about as 80s of a picture as we could come up with. So instead of a soccer style kick, I'm toe bashing, so that's good. I got my friend's dads in the background. One guy's sitting there drinking a beer. The other guy's got his aviators and mustache. He's having a good time. And then finally, I have this black tape. So what does that black tape mean? Well, if you weighed over 100 pounds, you couldn't carry the football. So you had to have a black piece of tape around your thigh. So this was the only time I touched the football was when I got to kick it. All right, but I had masked me then too. Okay, on we go. Was that joke funny? Oh, yes. I'm going to stop it right now, 100%. Oh, I know who said no. It's one of my friends in North Carolina, Mr. Sexton. All right, good. I like this poll. This is good. Okay, we'll leave it at 95%. Okay, so that was my other segue. Now we're on to our third thing. So in dermatology, we don't describe skin by ethnicities. We describe it by a range of types. And it's basically type 1 through 6. So here, here is a fairly basic description of this. And here's pictures that go along with type 1, type 2, type 3, type 4, type 5, type 6 skin. And there's a lot of people that we're treating that need ultraviolet light. It basically, we have one in our office. It's basically like a stand-up tanning bed. And it has narrowband ultraviolet B light and ultraviolet A light. And we use this for random inflammatory conditions like psoriasis, eczema, mycosis fungoides. But we do the dosing by Fitzpatrick skin type. So as you can imagine, for a type 1, you're only in the box for a minute or two. Whereas type 6 skin, a lot of times you start at 5 minutes and you may go up to 15. But that's where we use our Fitzpatrick skin typing. So, this would be interesting. Let's see the Fitzpatrick skin types in here. We have a nice mix here. This is nice. This spread seems very reminiscent of the patient population in Fresno, really. So I'll go ahead and scoot on here. So I was going to do a couple of different skin conditions and different skin of color. So here we have some central hair loss or alopecia. We have central all the way to the front right here. And here we have sort of temporal. This is called a central centrifugal cicatricial alopecia. It used to be called hot comb alopecia. And it's the most common type of scarring hair loss in African-American females. Now in our world, the major thing in alopecia is just the word for hair loss. The major thing is scarring versus non-scarring. Like normal male pattern hair loss is non-scarring. This is scarring. And what scarring means is you're never getting the hair back once that hair is gone. So it's scarring alopecia is very challenging because you go, the very first time you see someone, that's as good as it's ever gonna be. And you have a victory if you don't lose any more hair. So this is Dr. Amy McMichael. She's the nation, if not the world's expert on CCCA. She works at Wake Forest in Winston-Salem, North Carolina. I rotated with her in 2005 as a med student, as a little eager beaver, but she was fantastic. So what do you do with this? Like I said, most common form of scarring hair loss. We used to think, they called it hot comb alopecia. We used to think it was because of hair practices, straightening hair, heat on hair, etc., but it's genetics. It has nothing to do with the way the hair is treated. So what we do, like we do with all things in dermatology, you rub some steroids on it, or you do intralesional steroids. And here's a picture of me giving intralesional steroids. Some days I'm doing 100 to 200 shots in people's heads. I have certain people with CCCA that I've been seeing for 10 years, and every 6 to 8 weeks, I'm shooting them up 50 to 100 times. And this is what it takes to keep hair. And those people have a lot of dedication because it is not easy. 100 needles in the head is not fun. Now, other things we use is hydroxychloroquine or Plaquenil that Dr. Reyes is going to be talking a lot about later. I will certainly defer to her on that. Cyclosporin, I have a handful of people on that. And cyclosporin is a transplant medication. So you can have a kidney transplant or you have hair loss and you need cyclosporin. This is a pretty intense chemo. So it shows the links people go to try to keep their hair. And of course, we have them use Rogaine as well with as much success as any other topical. Okay, So Fitzpatrick 3, 4, 5 skin, we have this sort of hyper brown, hyperpigmentation sort of on bilateral cheeks. And this is classic. I get to talk about this about 5 to 10 times a day. This is melasma, another name for the mask of pregnancy. I have a little biopsy right here. And what you're looking at here, this upper area from there to there is the epidermis, okay? And then down there is the dermis. Basically, those are your two levels of skin. Right along the lower level of the epidermis here is the melanocytes. And those are the cells that make color. So they're making color to make you darker, tan you, a bunch of them clump together, it makes a mole. But what happens after you're getting, some genetics, some hormones, some sun exposure, a lot of that tan stays. And the deeper it goes down in your dermis, the longer it stays. So when we're treating melasma, if it's high up on the skin, we can have some success. If it's very deep, it's very challenging because that's about where tattoos are put. Tattoos are put sort of mid around in here, somewhere in the dermis, and they're not going anywhere. So anyway, like I said, it's some version of genetics, hormones, sun exposure. Now, treating it. Sun protection is the most important thing because you can do a bunch of stuff and you get it gone and you go out and get sunburn, it's back immediately. So you waste a lot, you'll waste a ton of your efforts if you're not being sort of very intense about your sun protection. What else we use? So hydroquinone is the main bleaching cream. You can get 2% over the counter. I can write up to 20%, but really only about 12%. And we have a pharmacy in Bakersfield that makes a little mix up for us, and they do it for pretty cheap. So that's how we do that. But over the counter, you can get 2% hydroquinone. It can definitely be worth doing. Tretinoin is like Retin-A or acne cream, and it's sort of peeling your skin, but it works against one enzyme in there to help to decrease the color. A little bit of steroids can help, of course. These azelaic acid and these other ones are some of the over-the-counter things that you can use, sort of antioxidants, certainly worth using. And then if you feel like spending money, there's a lot of things you can do. There's sort of mild chemical peels that you can do, a little glycolic acid, a little salicylic acid, or you can do deep ones. The problem, sometimes when you do a really deep peel, you look great for a minute, but then you end up pigmenting even more than you were in the first place. So with the Fitzpatrick 3 through 5 skin, you got to be very careful with your chemical peels. We are encouraging people nowadays, and it seems like it's helpful to do the micro needling. And that's basically, you can buy these off Amazon. It looks like a razor with a little bowling pin with needles on it. You punch a bunch of little holes in your skin. What that does, it's good for wrinkles, but it's also good to help your body sort of try to reabsorb some of that color. So for melasma, we're going sunscreen, hydroquinone, tretinoin, moisturize, of course, maybe a little bit of peeling and potentially some microneedling. Okay, so this particular lady here, she did quite well without anything too crazy. We didn't do laser, we didn't do anything like that. But she's susceptible to having it come back if she gets sunburned. Okay, all right, on to the next one. So this is sort of classic acne. And here's sort of what happens with acne. You have your hair follicle and the oil gland next to it. There it is. It gets clogged. It starts to clog up. And then these are, blackheads, whiteheads, papules. These are all the different things that can happen. So how do we treat this? Well, benzoyl peroxide and salicylic acid, these are sort of the classic over-the-counter treatment that you can get from Justin Bieber, if you'd like. So Justin Bieber, evidently it worked very well because he doesn't have too much acne scarring. I got to admit, I prefer the younger Justin Bieber than nowadays Justin Bieber, but his acne treatment works, so good for him. But now when we go to the next level of stuff, prescription-wise, we have the topical retinoids or tretinoin, Retin-A, which is quite good, but very drying. Topical antibiotics are fine. Systemic antibiotics, pretty good. Hormone therapy, this is getting even more popular. There's birth control can be helpful. There's 3 FDA-approved birth controls that we use. And spironolactone, which was classically a blood pressure pill we use for hormones. It's worked quite well. And then Accutane. Accutane is my favorite. It's the most effective for big acne. It certainly has its problems, but if you have terrible acne, nothing will necessarily work except for that. And here's the program you have to go through. And here's someone with Accutane. So she did quite well. And this is very inflammatory, nodulose, cystic stuff on her forehead. And she flattened out quite well. I mean, she has some makeup on, but she did quite well. She looks happier. Okay. So I believe this is the last skin condition. So we have here, she's happy. So this is, in dermatology, we're always looking if things are hypopigmented, partially lost color, or depigmented. And this is the ultimate depigmenting disorder. This is vitiligo. So what happens, we were talking earlier, I was talking earlier about the melanocytes, the cells that make color in the bottom layer of the epidermis. Your body's attacking them for some reason. So in general, about 1 out of every 10 cells on the basal layers of melanocyte. So whatever leaves in your white blood cells are getting rid of those. So you have spots that start small and they slowly spread. This is an autoimmune disease. It can be reversible, and it can be associated with other stuff like thyroid and diabetes. When I see a new onset vitiligo, I will certainly order TSH and hemoglobin A1C to check for diabetes in people, and sometimes vitamin B12 for pernicious anemia. But we can reverse this with topical steroids. You can do some light therapy, which seems a little odd, but that can be helpful. But that can be pretty good. Okay, now, if vitiligo gets bad enough, and I have a few people like this every year, you have to depigment everything, okay? And this is a cream that's called Benequin, and that's a 20% hydroquinone. And basically, I got to find that, and places make it and then stop making it because it's not illegal by any means, but it's a little much. But if 90% of your pigment is gone on your face and you just have a few still pigmented areas, you want to get rid of that because you want a uniform color. So I have a couple of people I see once a year, and we just keep them entirely depigmented. Okay. And here we have some models with vitiligo. So they're rocking vitiligo. We got body positivity, so that's good. This amount of vitiligo would be very challenging to get color back. In general, with vitiligo, if you have it on your face, that's the best place you could get color back. And the further you get away from your face, the less likely you are to get color back. But this is enough, you're not getting it back for the most part. Okay. Which of the following conditions have you had? I was about to say, I thought acne might win this one in a walk. The crowd's too young here to have melasma. I appreciate you laughing, Dr. Dillon. It's nice positive reinforcement.
Yeah.
Zoom is very challenging because you're so used to having people and interacting with them.
Yeah.
I'm just sitting here in my office, like by myself. At least I can see you laughing. Good.
Totally. That's why I try to keep my camera on because I
appreciate
know how
that. Yes. Okay, so it's acne. Acne won that one, no problem. I can't believe we don't have any alopecia, melasma, or vitiligo. That's kind of.
There are some in the chat that are coming.
Some in the chat. Okay. Yeah. Mr. Sexton, we might have some alopecia out there if you're still on. Okay. Conclusions. All right. So, as we learned from the plague, the best way to stay safe is avoidance. Now, that's very challenging. I mean, I think the mental health of everyone right now is very poor because of this. So we need interaction. I think you just try to stay as safe as you can. Are not function of 3 things: how long you're infectious, how do you give it to other people? Do you cough it up? You have to do something else, and how often you have contact with other people. The herd immunity depends on the R naught. The higher the R naught, the more percentage of the population needs herd immunity. And be aware of rashes that may accompany symptoms. As I showed, almost any rash can go with COVID. Now, the COVID toes are the most specific, most likely, but really you can have just about anything. As far as masking, wear your masks, try to stay clean while doing it, moisturize, and go to the doctor when the over-the-counter stuff isn't working. Okay. Thank you for coming or watching. All right, there we go.
I love
Good.
the masks.
Yeah, I had to put. I like the little mask graphic. That's as high tech as I can get.
I love it. Well, we do have questions. We have
2 questions. All right, good.
We'll start from the top. So, as a dermatologist, do you experience significantly less death among your patients than other physician specialties? What are the most difficult aspects of your job? Are there any difficulties most people don't know about?
Did they say, do I have less stress?
Yes, basically.
Well, to the other doctors on the thing, I mean, most likely, yes. I mean, there's a reason that dermatology is very popular. And it's very popular because, for the most part, our patients aren't super sick. Mm-hmm. I like working downtown because that way we do get to interact with the sick patients in the burn unit and be a part of the teams. I mean, a lot of things, a lot of fields, you feel like you're out there by yourself, and derm can feel like that. But down here, you know, like you were saying earlier, I got pediatric residents, internal medicine residents, med students. We just have a mob of people running in and out. So dermatology is fantastic. I can't complain one bit about it. I would say, each different field is taxing in different ways. Whereas surgeons is incredibly physically challenging, I would say derm is fairly intellectually challenging because, our hours are better than the majority of physicians, but the amount of esoteric knowledge, and this is every field, but I would say the amount of esoteric knowledge in derm, they really got to hammer us on that because, your residency has to be challenging. So if we're not challenging you physically, we're going to challenge you mentally. So I'd say that's one of the things in dermatology.
Yeah. I mean, just being in the ED when a rash walks in, it's always difficult because so many that, like you talked about, one specific rash can be from various different things. So it's like very hard to tease out what's actually causing it. What's the underlying cause?
Yeah. That was a long question. Did I get all of those?
It was, I think you covered most of it.
Okay.
Yeah. Would you say that anything specific that's like most difficult aspect of your job? Would that be?
The most difficult aspect of our job, is the rashes. It's funny in dermatology that really skin cancer and stuff like that, I believe, is a little bit more a reasonable thing to do. It's very tangible. You see it, you diagnose it, you cut it out. And there's varying levels of skill amongst the surgeons. So that is difficult. But the rashes are very challenging. I still feel like I go in the hospital and don't know what's going on. So I got to go back and look through everything and, all right, well, it could be 10 things and I got to go through all these different things. So I would say the rashes are the most difficult part of dermatology. Yeah, that's probably it.
Perfect. Yeah, I think that's good. How did you prepare yourself in medical school for your dermatology residency?
That's definitely studying very hard. This is, I think with dermatology, it's a bit challenging to get in it. It's just the supply and demand curve. There's only about 350 spots in the entire nation available each year. And it's a wanted field. So the supply and demand curve, that's how it goes. I did kind of figure out I wanted to do it part way through my third year of med school. So I started doing away rotations. And that's where I was talking about, I rotated with Dr. McMichael in Wake Forest. And Wake Forest is really a powerhouse of dermatology. Actually, I went from Tennessee out to UCSF and I rotated in San Francisco as a med student. So that was fantastic. It's one of those things you got to identify it early and start, kissing up to the various people you might need to kiss up to, or doing the research, et cetera, to get the grades. I mean, when we're looking at, there's minimum scores. If you're below it, then sorry, you got no choice.
Perfect. Were the medical treatments performed for the plague the same or different than at-home treatments?
So nowadays, the plague, we've got a nice array of antibiotics and we just treat it and you'd be A-okay. If you missed it for 2 days, you could die. It goes very fast. I would say back then, it was the same everywhere. Nobody could do anything. Antibiotics really weren't around until penicillin was sort of discovered in the 1910s, 20s, something along those lines. It really wasn't mass produced until World War II in the 40s. So there was no antibiotics. Everything was just kind of throwing everything against the wall and see what sticks. So I'd say now we treat it, no problem. Then good luck.
Yeah, totally. What is the relationship between dermatology and infectious disease? Do you need an additional fellowship to see patients with infectious diseases?
So yes, so this is a completely, so infectious disease doctors are fantastic and they have some of the hardest jobs in the hospital. They do a 3-year internal medicine residency and they do a 2 to 3 year infectious disease fellowship after internal medicine. And it used to be that infectious disease did dermatology as well. And then maybe it was the 40s or something that dermatology became its own residency. And originally dermatology was the Academy of Dermatology and Syphilology. So originally you were good for dermatology and syphilis. But then like I was saying with penicillin, when penicillin became widespread, you didn't need to be a specialist in syphilis anymore because you get one shot and you're good. So then it was just dermatology. But originally infectious disease doctors were the dermatologists. But now it's pretty much separate fields. But we like it. I interact with infectious disease docs all the time. Dr. Libke and Nasser and Saxton, it's a great crew.
That's awesome. I actually didn't even know about that derm and infectious disease were sort of connected. That's awesome.
Yes.
I know they go hand in hand quite a bit, but did not think of that.
I have one question. Does anybody know what this is? So if any of you work at the VA, every day you get a sticker And we're 204 days into this pandemic.
That's
Every time I
awesome.
go there, I get this sticker and I'm just like, 204 days. Oh,
I love it. I have like the daily stickers on my badge and I'm putting them on top of each other and I'm pretty sure
yeah.
3D is like about this big now. So
Yes.
yeah. Okay, next one is, what is it? No, wait. Can wearing hats mess up your hairline if you wear hats?
Not particularly. The problem we have with hairlines more than anything is traction alopecia. And this is when people are pulling their hair back hard to put it in a bun, a knot, cornrows, stuff like that. That is a little bit more of a problem. The thing would be a lot of times people are getting androgenetic alopecia or male or female pattern hair loss, and they're getting a little friction from the hat. So that might speed it up a little bit. So I would say primarily short answer, no. Long answer, little.
Okay, that makes sense.
Yeah.
Is vitiligo genetic?
Absolutely. So there's some percentage of the time that it's a new mutation, 30 or 40% of the time, but a lot of times it is, you've inherited it from some family member. In general, with vitiligo, the earlier you get it in life, the more intense it's going to be. And it kind of likes to play the way it played. A lot of times it'll be on a segmental side, but when it's all over the place and what's on your hands and feet, in general, you're gonna have trouble getting color back.
That makes sense. What happens to the skin when a tattoo is removed?
Okay, so the tattoo removal has actually gotten significantly better in the last few years, rotating from a nanosecond to a picosecond laser. And lasers are basically just really, really one single wavelength of light. Primarily, if you know the rainbow is Roy G. Biv, well, the laser that we have is G, it's green. It's like 545 nanometers or something like that. It's one very strong version of a wavelength of light. And what this does is these different lasers zap different colors. So say it hits black or blue, different laser might hit green or yellow or red. And what it does is it zaps it and it tries to make your own body's macrophages or histiocytes collect the pigment and make them go away. The newer lasers are a little bit more effective. They can get a little bit better focus on the actual pigment. Depending on the color, sometimes it works great, and sometimes you do it 6 times and you end up just cutting it out anyway. So, but it is getting better.
Is there anything you can do to promote beard growth if somebody wants it?
Not really. The wives' tale about shaving more and making more hair grow, it certainly seems like that, and I feel like that myself, but that doesn't really bear out with the evidence. You could, actually, I take that back. You could certainly use Rogaine or minoxidil generally for male-female pattern hair loss. You can put it on your face. That could help. And a lot of times occasionally that's a side effect for women using it on the head. They'll have some excess hair growth around their face. So I imagine it wasn't a female that was asking that question. But you could use Rogaine on the face. Why not?
Are you from North Carolina, Dr. Simpson?
I am from Nashville, Tennessee.
All
right. I went to college in Chapel Hill, North Carolina, of which I thought I saw 1 or 2 of my friends on this chat, and I appreciate that.
Yes.
And then between college and med school, I was at UCSF working with mice, and that's where I met my lovely bride from Fresno. Went back to Tennessee for med school, then DC, then Georgia, then back here 10 years ago.
That's awesome.
Yeah.
Well, I'm glad she recruited you to come to Fresno.
Oh, yeah. Central Valley Pride.
Perfect. Yeah. One of the attendees is asking that they've been to a dermatologist before to ask about hair loss, and they were told that it was due to stress. What would you recommend other than what you've already mentioned?
So for men, really, there's really 2 things that are proven right now. That's Rogaine or minoxidil over the counter. You can get it at Costco. Minoxidil is generic. And Propecia, which is prescription medicine. Both of those may be somewhere between 70 to 80% effective, and doing those both together will be even more effective. Certain people do this light treatment on the head, a little fluffy, but could work. If you feel like spending some money, you can do the PRP or platelet-rich plasma. I do not do that. Certain people do that in town, and it may be $300 a pop. You go in, you get blood drawn, they spin it around in a centrifuge, they take out a certain layer of the cells, and they inject it into your head. And the thought is that they're pulling out a layer of growth factors that you put in the head and try to regain, these growth factors around the roots of the hairs. Because as I was saying, with male pattern hair loss or female pattern hair loss, the hair follicle isn't gone yet. After a long time, it's pretty much gone. But in the early stages, you can get it back. And it all depends on how much effort you want to put in and how much money, really.
Okay. There's a couple questions I'm going to put together about just medical school and residency.
Okay.
First of all, how many years did it take you to become a dermatologist?
Okay.
And then do you allow students to shadow you?
Yeah. So with dermatology, it's 1 year of internal medicine, like the intern year. Everybody does an intern year. And that's what I did, internal medicine. And there's 3 years of dermatology after that. And I'd say that's reasonably standard for the different sort of specialties, reasonably. We do have, right now the COVID, I had multiple people that were set up to rotate this summer, but I think UCSF just said is all the way out to June 2021 now for no rotators, correct?
Yeah.
Yeah. So we're out a ways because of COVID. The med students were out of the clinic for 4 or 5 months there, or 3 or 4 months.
Yeah.
So it's kind of a tough time right at the moment.
It is. Yeah. What's your favorite part of your job?
In general, I have a very happy patient base, and we have fun, and I get to goof around and have a good time. So I like that, but really, I like the interaction with my fellow colleagues. The residents know I'm always talking a lot of trash to them, but it's all with love, trying to help them learn. But we try to joke and learn at the same time. That's probably my favorite part. I wouldn't want to be just sort of out by myself in a clinic somewhere. I like the camaraderie around here, and getting to go in the hospital and breathe in COVID every day. That's nice too.
Yeah, you're right. Exactly. Yeah. Change of scenery. Yes. Yeah. There's actually a pretty good question. It pertains to our population. What are some options for patients in low-income communities who have dermatologic diseases and their insurance doesn't cover it, or they don't have insurance? What can they do?
So we have a family healthcare network clinic that's quite good, and I have 2 clinics there. I have an adult clinic there and a kids clinic there. We have a telederm clinic that operates out of Porterville. But a lot of times for people, we see people sort of just cash pay all the time. We make it as cheap as we can, just because we're trying to help in any way possible. One of the problems is the sheer volume of paperwork that each one person, has. So, but a lot of people, Dr. Dillon, I saw from our old things, a lot of people text me pictures all the time. So I love getting that, because if I don't look at my phone for 4 hours, sometimes I look back, I'm like, I've got 10 interesting cases here to look through.
Yep.
So a lot of times I try to help in any way possible. But that's a great question. And it's a huge problem around here. And I say we do the best we can, try whatever we can do.
Yeah. Well, we do really appreciate it. I know sometimes emergency medicine residents abuse that number. So we're like, text you because we're working middle of the night. And we're like, we'll just text this to Dr. Simpson. And I was like,
yeah.
It's middle of the night. Yes.
So I just noticed I'm drinking out of a Raiders cup. I like the Raiders fine, but I'm generally a Titans fan, having grown up in Tennessee. But I just was curious if anybody saw that. I didn't even notice.
Well, there's a question. I don't understand it because I don't know anything about sports. I don't know if it has anything to do with sports. Are you Wolves fan or Tar Heels?
Oh, both. Oh, absolutely both. Die hard. And any of my college or med school friends know that when they play, and they've played maybe 3 times since I've had degrees from both places, it's very, very stressful for me. And so I cannot answer that question adequately. I love both of them very much.
Sorry, we're running out of time, so I'm going to ask just one general question, sort of put together. Anything for scarring? I think that's what's coming up the most.
Oh, scarring! Oh my gosh! So acne scarring is very challenging. I go back to the micro needling. Okay, so the micro needling is quite good because like I said, it punches multiple hundreds of tiny little holes. And what's that doing is it's stimulating collagen, stimulating your collagen in that area to sort of puff out. It brings a lot of growth factors, like I was talking about, to the area. And what that does is help sort of slowly even things out. If you're going to do that, it's painful. You got to be clean and all those sorts of things. So if you're going to do that, start with 0.5 millimeter microneedle. And as you can imagine, the bigger the microneedle, the more effective it is. And it's a slow process, and you're sitting there punishing yourself. But that is probably one of the most effective things you can do at home. On top of that, moisturizing sunscreen like a crazy person, and then the tretinoin that I was talking about. Those three things, without spending a bunch of money, that's probably your best bet.
Okay, perfect. Well, it seems like a lot of people enjoyed your presentation, so thank you. They love your personality as well, from what I can read in the comments. So thank you very much for this great presentation. We really appreciate it.
Thank you.
So I'm going to go ahead and introduce Dr. Reyes. She's our next speaker. Dr. Reyes is one of our rheumatologists here in Fresno. So she actually did her residency at Yale University, Danbury Hospital, and then finished and did her fellowship in rheumatology at Brown University, Rhode Island Hospital. She's been a doctor for past 18 years, and she specializes in rheumatology, like I said, and she works here not only just at CRMC, but also at the VA. So that's pretty amazing. She's skilled in immunosuppressive treatment of various autoimmune diseases and the use of rheumatology-specific musculoskeletal ultrasound, which is pretty amazing because musculoskeletal ultrasound can be very complicated because there's so much of it. So that's cool. She's received multiple teaching awards and nominations. Her focus mainly is lupus, rheumatoid arthritis, myositis, and gout. She's one of the faculty resources for Doctors Academy as well, so I'm sure some of you have already met her before. So she's very much interested in empowering the young students in Central Valley who are considering medical career paths. That's pretty amazing. Some interesting facts about her. She is a student of traditional, I might mispronounce this, Shotokan? How do you say it? Okay. Karate since 1996 and continues to practice karate in a local dojo in Fresno. That's amazing. She has 3 children, aged 23, 21, and 10. I would have never guessed that looking at you, Dr. Reyes, that you have a child who's age 23. That's amazing. She loves watching movies such as Star Wars, which is pretty good. A little story, when I first moved from India, when I was learning English, my first movie that they played in high school was Star Wars, and I thought, I just didn't understand any of it because that was a completely new concept to me. But now that I go back, I do enjoy those. Yes.
Thank you so much for that kind introduction. And I appreciate being able to talk to all of you here at Mini Medical School. I am pleased to follow Dr. Simpson, who's really been such a good colleague, teacher, and clinician. So I appreciate having me follow him, and hopefully there'd be correlation with the cutaneous or skin manifestations as I talk about lupus. Here is my talk, and I hope you can see it clearly. This title, I didn't mean to make a pun of the masks, just that it's so mysterious that if we can uncover lupus even for a little bit, that's already, to me, very a high honor, because I need all of you for us to help our autoimmune disease patients, because nationwide there is a dire shortage of rheumatologists, and as well as globally, we deal with conditions like lupus, which is an autoimmune disease. Sorry, this. Rheumatology is my specialty, and I've had this inclination ever since my 4th year in medical school, having taken care of a lupus patient. But it's a very different scenario, different time, different space, and that there has been so much advancements that I feel we can really help these patients, while our specialty deals mostly with autoimmune diseases or inflammation conditions that you may or may not be familiar with. Its examples are rheumatoid arthritis and gout, and also conditions that are more related to everyday overuse that we say when there's repetitive movements like tendinitis or trigger fingers. But autoimmunity is my focus now, as well as its treatments, with a highlight that it is the multisystemic nature or many organ systems involved in autoimmune conditions that makes it quite challenging, but also interesting. And hopefully I can gain some of your interest so that in the future we can add rheumatologists, particularly where we need it here in the Central Valley. To talk about autoimmunity, we need to have an idea of the immune system. It is so fascinating when learning about immunology based on physiology, anatomy, really is um, the epitome of medicine, I'd say. The immune system fights for us. It prevents as much as it could infections, viruses, bacteria, germs, pollution, anything foreign to the body is what the immune system is designed to fight. But also unknown cells like cancer cells. So immune cells try to fight off those which are foreign, and that's tumor cells. So that concept of it can also be a means that we clear out cancer cells if it doesn't overpower our system to do so. It also mainly has the job of eliminating infections. So it is so intertwined with how our public health system is trying to understand the immune system effects because of SARS-CoV-2 is the virus causing COVID-19 disease, the current pandemic. And that's one of the infections that has a link to how the immune system is fighting it, driving to therapeutics in this current pandemic setting, tapping into medicines that rheumatologists use for immune suppression. But sometimes it malfunctions, such as when it's hyperimmune state. Imagine if it can attack our own organs, or that it causes normal organ systems and joints or skin to malfunction or have abnormalities. That's the root of autoimmune disease. You might already be familiar. Type 1 diabetes is an autoimmune disease, and so are other conditions I've listed here. And technically, it is by mistake. Nature didn't design our immune system to attack ourselves. So I think we should forgive it and be more understanding, but get to know how we can help fight against it. And sometimes we commonly may have a loved one who has conditions that are listed here. What I didn't list is rheumatoid arthritis. That is definitely, if I'm invited back, that can be a separate talk, but it is an autoimmune disease specific to attacking the joints. While we will talk about inflammation first, because that is the basis of how the immune system problems cause damage. And inflammation, the way to think of it is if ever you've had or know of someone who's had an ankle sprain, that sprain would result in a swollen ankle. It's red and swollen and hot, and you can barely bear weight on it. It's because our cells, with the multitude, so much immune cells and very intricate and complicated cytokines, they fight off the bacteria from a wound or make the swollen tissue, a torn ligament, heal. That was the purpose. But if it is such condition like an autoimmune attack on the joints, like rheumatoid arthritis or lupus arthritis, unknown why, but it prefers small joints of the hands depending on which condition. There are various conditions that would make it choose maybe a wrist or a knee, while the hands can be commonly what we encounter for lupus or rheumatoid arthritis. So inflammation, that concept is at overdrive when there's autoimmune disease attacking organs or joints or skin. With lupus particularly, that is the prototype autoimmune disease because it's how exactly what autoimmune means, the body system attacking our own cells. Systemic meaning multiple organs from head to toe. It can be involved with lupus, but we coin the terms SLE or lupus to be easier to say. This was the first known photograph or drawing of lupus. This is in 1856. In the chat, though, can I ask if anyone knows what the term lupus means? It's a Latin term, but if you've heard of what it means, might be something you'd remember.
What are the participants mentioned? Lumps?
That's very close, and that reminds me, I didn't mention, but yeah, lymph nodes, like Dr. Simpson had an image earlier. Lymph nodes can cause lumps. That can happen in lupus. But I think that should be the actual Latin meaning. It is a Latin term for wolf, and it's so unclear why it is named lupus. There's many anecdotal reports why, but just that translation of lupus is wolf, and maybe in case it can remind of the rash with a wolf-like appearance. But yeah, that's still a mystery if any one of you can find out. Our lupus problems happen in as much as 1.5 million people in the United States. While it's not clear how many actual lupus patients are with for sure lupus or probable lupus, because there's so stringent ways to diagnose this that it's not really clear how accurate those numbers are. But that we know that most of them are women, and that it's in our childbearing age of females, 15 to 45 years old. So more common in females, but it also can occur in males, also in childhood, and can present in the elderly. Our healthcare disparities are apparent with conditions such as lupus, which is more prevalent. It's more common in Blacks and Hispanics, Asians, Native Americans are more at risk than Caucasians. And what we've been finding is that if it is presenting in a male patient, it tends to be more severe, meaning more organs involved, or if it's one organ, it's just a higher chance that it's severe, such as kidney lupus, and that may require dialysis. And to give an idea of the features, the rashes are the most striking, so you could recognize it and know if someone needs to be tested. This is the characteristic butterfly rash or malar rash, where this is the malar area. My lights shut off. So the butterfly shape, to remember it. It can have a different characteristic, the scarring kind of rash called discoid lupus, discoid rash or discoid lupus, where it leaves scars, while this butterfly rash can resolve and not leave marks. Articular or joint disease is common but different from rheumatoid arthritis in that it doesn't have similar extent of damaging the joints. And this is the knuckle joint here, this other picture. And inflammation of that lining of the joint is called synovitis. Those are more external features of lupus, but internally, any organ, from joints, muscles, stomach tract, skin, heart, and lungs can have inflammation as well along the lining, the outer lining of the heart and lungs. The eyes can have inflammation, and blood cells can get attacked, causing anemia or low blood cells. Kidney failure is one of the most severe manifestations. We have many patients here in the Central Valley who has severe lupus nephritis. We have many more options of treatment now, but that eventually, or if not caught in time, dialysis or kidney transplant might be needed. And brain inflammation also can happen. Can I please ask this question? Anyone in the chat, what causes autoimmune disease? What do you think? Can't see if
It says immune cells attacking the body, your own body attacking itself,
yes.
overactive immune system, genetic.
Perfect. Yeah, definitely it's a mixture of those, but that I was seriously asking because nobody really knows. So it's not yet known, but it is a combination of that genetic predisposition, people who may have that as part of their genes to form antibodies to our own cells, and may be triggered by, is it pollution? And in fact, this is one of our studies here with UCSF Fresno. We're trying to study with the residents if this particular air quality index that we have, can it trigger lupus flares, knowing that sunlight exposure triggers lupus. So immune system abnormalities and hormonal factors, especially knowing that it's female predominant disease. Diagnosis of lupus can be tricky, but can be also straightforward if supplemented with these combination of tools. History is what their symptoms are, as well as when things presented, what joints or problems they've been experiencing, as well as a sharp clinical examination. And that's what I teach. That's something that we always review at our clinics through medical students and residents rotating with me in rheumatology. We have a lot of emphasis on the musculoskeletal exam, actually closely related to different paths if this would be honed. History and PE can really make a diagnosis of many conditions. But yeah, towards sports medicine, towards any field, this is my emphasis, to strengthen history and physical exam, while laboratory tests and biopsy of the affected organ, taking a sample of tissue, is really more conclusive. There are sets of what's called criteria, but this is especially during the path towards training for being a rheumatologist or as a medical student. These criteria are meant for us doctors to include patients in clinical trials where drugs could be given, or just that. It's also a reminder, though, that yeah, it can affect blood counts, kidney, helpful to know, mainly as a guide on what to think of. And the blood work, that lab test, ANA is the most important to know about. Autoantibodies, meaning antibodies against self, like one of few of you said in the chat, that's one of, it's called or recognized as a screening test, and it's formed against the body's nucleus. Inside the cell, we have a nucleus, and the target of the immune system becomes that nucleus. Then the blood test would be positive for that anti-nuclear antibody. This picture shows a virus, antibodies forms against that, so to wipe it out. But autoantibodies attacks a healthy cell. So autoantibodies is how we term the attack on our own cells, and other antibodies that is tested in the lab can give us an idea on what other features and might be not lupus, but in similar category, because there are other autoimmune conditions as well that these antibodies can speak of. treatments that Dr. Simpson alluded to, this is particularly a rheumatologist's medication, hydroxychloroquine, as well as steroids and immune suppressive therapies along the lines of chemotherapies, as well as now biologics, at least we have. But I'll mention and just quickly browse through hydroxychloroquine, just that to know that we have a limited number of options for treatment of lupus, most commonly steroids like prednisone and dexamethasone, which is the same steroid used for COVID treatment, and immune suppressive therapies similar to what's used in cancer. So that's going to represent that how it intersects inflammation and the immune system, infections, and even cancers, because we can see that they might overlap using the same cells for its own purpose. And so we can imagine the side effects of some of these therapies might affect their ability to fight infections, as well as other severe side effects that steroids can use. So it really has to be used properly and in the right setting, guided by a rheumatologist or other specialists who are familiar with these drugs. There is so much detail about hydroxychloroquine. That's why it's hard to explain how it also was felt to be possibly useful for antiviral therapy. But the idea is it may block some antigens or like viruses from entering cells and multiplying. But that concept was not highly proven to be effective in COVID-19 treatment, whether or not it's based on the timing of when it's used. So the most that I'd like you to take away from what hydroxychloroquine does is that it is an immune modulator. It doesn't suppress the immune system, but actually modulates and calms down the immune system. So that's why it doesn't really have the same effect of what a cancer chemotherapy can do, which is suppress the immune system. Therefore, it might present us more infections. In the news or elsewhere, maybe you've heard that this might be a scary drug. These are very rare problems, eye conditions, heart conditions, and only things we've seen as rheumatologists with long-term use, decades, 5 years, 10 years, 20 years, and even then it's rare to find these side effects. The use of hydroxychloroquine has been with us since 65 years now. And even now, we have no need to check blood work, except in certain situations where we might fear there might be a blood side effect in those who have an enzyme problem with their blood. And this is theoretical, where maybe it can interact and cause the opposite effect with what we intend to treat the body with. It might induce some problems like psoriasis, rarely. That is something of a nutshell for lupus, but in the next slide, I'd like to highlight with you how our immune system definitely interacts with similar cells, and just to represent how all cell lines are part of what's called the inflammation cascade. And this is how COVID-19 is acting on our immune cells to trigger that hyperimmune response that, since we've learned how this condition has been affecting people, has become fatal for those who have hyper stimulation of the immune system. That's the interlink of infection and inflammation, while these same cells are where therapeutics are being studied, if it can help. So we're rheumatologists, but definitely interact with infectious disease, dermatologists, as well as most of the other specialists So in a sense, we're not specialists of a certain organ, like cardiology specializes in the heart, but mainly in multi-organ conditions, as well as our therapies, our treatments, and the knowledge of immune system might help when we understand infections like the pandemic that's also been happening. This phase 2 is where over time that we've gotten to know COVID, there's been the first few days that's really viral infection, while the phase 2, where it can be in the ICU, is immune mediated. So now it's really something more familiar what immune mediated means, even if the problem was an infection, because it drives the immune system. As a summary, and because I'd like to have some time for questions, I'd like us to just realize that the immune system, it's a lot of times the students or residents who will come to me, they feel it's so complicated and complex, but that it is fascinating, and just that it's there to protect us. Dysregulation, or the body having a problem understanding that it's not supposed to be attacking our own organs, that's what causes autoimmune disease. Lupus, which can affect all organs in various combinations, not all at the same time, is representative of autoimmune disease, but uh, this disparately affects Blacks, Hispanics, Asians, and American Indians mostly. And we have a large population of patients with lupus here in the Central Valley, as well as in definitely globally, this condition is seen and needs our help. Hyperimmune stimulation can be overpowering to a degree that if the body was trying to fight an infection, this can be a problem and lead to what's called a cytokine storm, which also might be a large proportion of deaths represented by the condition of COVID-19, where the ultimate purpose was the immune system was trying to eradicate the virus. This is a poem I made, and if I can say it for 1 minute, this is something I composed in April. And if you can imagine the times we were in those times, this might still be applicable. No. Sorry, I'll read it out. The uncertainty is certain. Let us drop the curtain and mask this serial killer's intention. Attack of its clones gone viral, made distancing societal, disrupting every human convention. Now, humble hydroxychloroquine, now forced into the scene, telehealth bridges our care. Drive-through testing, PPE and sanitizing, social media fills the air. But let's not be deceived. This virus evilly conceived a plan to evade the immune system, inducing cytokine storm, wanting ARDS to be the norm. Treatment data still a schism. We will beat this pandemic through strategy systemic, from hand washing to quarantine. Forefront professionals relearning the essentials to defeat you, COVID-19. As we navigate each virtual lecture at this oddly remote juncture, we dissect this murderer's crime, blending infection with inflammation, COVID-19 plus lungs and heart and organs and rheumatology equals one life at a time, which should always be our focus as we care for our patients, no matter what condition, what specialty, or what field you may choose to go into in the future. And with that, I leave you with this, that it is complicated to learn about the immune system, rheumatology, and autoimmune disease, but fortunately, learning and teaching, as well as research and treatments, have advanced so much that we have more options and ability to control inflammation and autoimmune conditions because it's been advancing over these years. And it is with humility that I seek your help to go into this field, because we can truly help patients the way I've experienced that we've made a difference. I think we definitely need more, especially in the Central Valley, where we need more healthcare providers to continue such care. So thank you very much. And I'll want to answer some questions. Thank you for your attention.
Thank you, Dr. Reyes. That was amazing. I think rheumatology is, like you mentioned, I think we need more people who want to specialize in that field, because it is a very complex field, just because there's so much that goes into it. It's like you said, it's not one organ that you can focus on. It's literally your cells in your body that end up attacking or doing something opposite of what they're supposed to do, or just as an auto. It's very interesting. Actually, one of my best friends is doing rheumatology fellowship in Canada right now. So that's pretty amazing. Yes, and she's taking her boards soon, so we'll see how that goes. There are a couple questions. One of them is, can interferon be used for lupus?
That is a field of study. Interferon signature has been found in lupus, where there's a particular genetic expression of interferon, and that if to target interferon gamma, there's therapies, but not yet out in terms of having results that are good enough to be used as treatments. But that's very good insight that, yeah, it is an up and coming, meaning maybe 5-10 years already known, but studies are still ongoing.
Right. So lupus is a disease our body makes cells that tries to harm our own cells?
Yes, I did need to clarify that. Thank you so much for that question. Our body does encounter autoantibodies. We form antibodies at low levels to cells that are supposed to be normal, like thyroid cells, but it's a very precise mechanism at the molecular level that the body distinguishes that it shouldn't be too heightened, because it will be overpowering and causing organ damage. So it learns that it will attack forming antibodies to our own cells at low levels, but immune regulation mechanisms tone it down. So most people don't develop autoimmune disease.
Awesome. There's a lot of people, it seems like, didn't know about rheumatology, and that was one of the main reasons we wanted to bring you on, to educate people about it. They said if they wanted to learn more about lupus or rheumatology in general, where do you suggest they go?
Here, and rotate with me, because
Yeah.
I'd love to teach. And there are, can I type here in the chat, the most valid and reliable source is American College of Rheumatology, or rheumatology.org, sorry.
Okay.
Just that it's the body of rheumatologists nationwide with screened and verifiable data, as well as handouts for anyone in the public to download quick reads for diseases or treatments, as well as more in-depth reading in terms of the conditions, its criteria, or its developments, such as updated treatments for gout. And that also can help primary providers as well, because that website would have accessible information as well as learning materials, aside from textbooks, and should be reliable websites if you're going to go online.
Perfect. Do rheumatologists help in some psoriasis diagnosis and treatments, or only
Yes.
dermatologists?
No, we intersect that way. 30% of those with psoriasis rash can develop psoriatic arthritis, and that can be a very severe, disabling arthritis where it needs immune suppressants at the level of chemotherapy like or injection types, and still pills in combination to treat both the rash and the joints. But just to highlight also, might be for the next question, but that psoriatic disease, psoriasis and joints, have similar treatment options, while psoriasis, if not severe, can be alone steroid creams.
Yeah, the next question is, how does rheumatoid arthritis differ from other forms of arthritis?
I wanted to talk about that so much, but yeah, that's a very good question because it highlights what we will encounter most commonly. Osteoarthritis is the most common arthritis and will develop in most, if not all, as we age. It's the wear and tear of the cartilage, and that's why it's nicknamed arthritis. Rheumatoid arthritis itself is an inflammation type of arthritis, while osteoarthritis is uh, wear and tear or degenerative, meaning the activity of the joint will lead to its development. But inflammation causes damage of the joints, so they can also hurt from secondary arthritis from the more common arthritis. But there are different areas that will help distinguish. Rheumatoid arthritis doesn't affect the spine. So back pain is not going to be suspicious for rheumatoid, but for osteoarthritis. And rheumatoid and lupus arthritis can be similar. So that's why the concept is inflammation arthritis, or the arthritis that we call being the regular degenerative arthritis is what we might mean when somebody mentions we have arthritis. And that's something you probably can be seeing day to day. Knuckles hurt, but there are certain areas. If it's here, rheumatoid arthritis, lupus, those are favorites of rheumatoid. So it also depends on which areas, and then further testing through their doctor should be pursued if this is in question. So we have specific or treatments that will really calm down that immune system arthritis.
That makes sense. Do rheumatologists also work with immunologists at any level?
Yes, we're technically trained or immunology based as foundation of rheumatologist learning, but immunology is its own field and it can be interrelated with allergy and immunology, but there are rheumatology programs that are rheumatology and immunology because of that common ground. But immune diseases, immune deficiencies, they have a different subset that really is intensely known by immunologists. Commonly, we might share similar conditions because of that foundation in immune system diseases.
There's another question. Before I ask that question, I would like to ask, in order to become a rheumatologist, what kind of training do you have to go through? Just so that for people.
Mm-hmm. So medical school of 4 years, and then an internal medicine residency for 3 years, 2 years of rheumatology fellowship training. There are some that are 3 years rheumatology. Those are the ones very interested in research, which is only certain universities carry that. But after pursuing an internist or medicine career, different from the path of after med school, surgery, residency is further training, or pediatrics, internal medicine, and that's a specialty of internal medicine to become rheumatologists.
Okay. Are there any subspecialties within rheumatology?
Subspecialties? with rheumatology. No, but sub-interests like musculoskeletal ultrasound certification, which I've acquired, that's more of sub-interests, and certain centers develop our own that we also are trying to fortify here, a lupus center and myositis center, because of our interests and the research studies that we're trying to build on. That's more of a sub-interest rather than subspecialty under rheumatology.
That's awesome. Could you, what is like the most common, I know you talked about lupus here in the Valley, what are the few different autoimmune diseases that you see the most of that people should be aware of?
We have a unique population of the Hmong, and that's also my plea that if there is anyone who may have any ability to reach them, because conditions like gout can be common in certain ethnicities, and Hmong that I've only seen here in the Central Valley compared to in the East Coast where I've trained, it's very prominent, but I think very advanced. So based on the values and culture of a certain population, it might be, is it the behavior of seeking care, or how accessible we are to treat conditions like gout. Lupus is very prominent, especially Hispanic population, and the burden of severity, it's really quite severe when we have them at their very young ages. Rheumatoid arthritis is very common, as well as not very common, but highly important to recognize, myositis. While if at the VA, conditions like gout and osteoarthritis are more common. So the more common conditions that rheumatologists see are quite common here, but certain rare diseases are also florid in our Central Valley. But inflammation is the root of all these conditions. That's why primary doctors, emergency room doctors have been helpful teasing that out, and then routing their referrals to us to help directly with those conditions.
Yeah, it's always, you know, when a person with autoimmune disease, like let's say lupus or rheumatoid arthritis, comes into the hospital, it's always, you know, there's other challenges that they come with, of course. And one of the biggest reason is because they're on medications that potentially make them more prone to getting other infections. So that's always something that's challenging for us here in the emergency department, and something that, you know, always been, you always learn more and more. The more you see them, the more you learn about different medications and different treatment options, and it's pretty amazing.
That brings up a key point too, actually. Infection is still more common. So if someone has autoimmune disease, it's to think of what common things would be more common, to not presume it's a flare-up of their autoimmune condition, but if they had symptoms with their breathing, to think of pneumonia. So it's not and or this, it can be both. So it's very different treatments. So recognizing if that autoimmune condition is in a flare, but may have been triggered by having an infection. So it's not necessarily recognizing one, and that's the only thing that will cause them problems. It can be a lot of things intersecting, and just really have to be both treated.
Totally.
And that's the judgment that as clinicians will always have to work hand in hand collaboratively with other doctors. And I said 2 points. The other point is, when somebody has joint pain, that's a common concern. It's not necessarily a concern for autoimmune disease. Pain doesn't necessarily mean lupus. Sometimes that can be the weight of how we get concerned that they're gonna be scared. But pain itself is one of the most tricky symptoms. So pain is driven by inflammation for those who have an autoimmune tendency. That's why blood work and inflammation markers in blood lab tests can help sort that out. But pain per se doesn't mean arthritis, and pain itself doesn't mean inflammation.
What would you say, I'm just going to ask one of the questions. What would you say is the most difficult or challenging part of your job?
It is the multitude of patients we need to serve. I enjoy and love my career and profession and being able to teach. It's just that it's not enough, and the wait time is depressing. It's just so much wait time for patients who need rheumatologists, and it's not like um, a matter of just hiring someone. There's not much rheumatologists being produced in proportion to the need, such that in year 2030, the need of, this is adult rheumatologists, that's I mean, pediatric rheumatology is different. 2030, the projected need for rheumatologists are 8,452. They did this workforce study, while the actual number that will become in year 2030 is 3,500 something. So it's really that gap that I need all of you to consider rheumatology.
It's a huge gap. Wow. That's super.
And arthritis is not going away. So arthritis and autoimmune, sorting that out and helping directly.
Yes.
Even not going to rheumatology, having rheumatology knowledge, because they'll walk into not a rheumatologist clinic directly, but
Yeah.
any one of you interested in pursuing a medical career will encounter back pain, joint pain, rashes, and inflammation.
Yes. I see it in the emergency department. Dr. Simpson sees it in his office. Everybody sees it. Yes. And then it's always, you have to determine, is this an autoimmune disease that you're missing? It's always the fear when the person shows up the third time and you're like, it might not be a simple thing. And this might be something, there might be something more to it. So it's always nice because I know we have rheumatology on call. So that's actually very beneficial, especially when patients have rheumatologists. It's very easy to get hold of them. And we really appreciate that.
Oh,
Department.
thank you.
Yes.
That's me and Dr. Kazarian. We're
yes,
just out
exactly.
too.
Only two. Yes, I know. So we really do appreciate that when we have questions that come up. I think there is.
I see the chat messages, and it's also wonderful to hear from the audience.
I know. There's
and
one.
I hope we would also have more time or topics that can be requested. That's something that we can definitely tailor a talk to.
Yeah, totally. It says, does the need for rheumatologists differ significantly by geographical location?
Yes, so good questions. In the East Coast where I trained, it's like they compete for patients. They can just choose one street across each other. The Central Valley is different from the California. There are many rheumatologists in California, but there's only 9 of us in Fresno County for 1 million population. So one of them is retiring. There's one in Madera also. There's one in Han. So just you can count. So it's really Central Valley. If the numbers for California are counted, we might not really see that it's very needed here proportionately for patients in need.
That's amazing. Yeah, that just blows my mind. I mean, we already know Central Valley lacks in just doctors to keep doctors here.
Mm-hmm.
And then some diseases that are so complex and it's so difficult to bring those specialists to the valley or keep them here if they were to become specialists in rheumatology. Is there a certain demographic you see most commonly in your patients?
Depends on the clinic as well. The veterans, mostly male, but also female. I mean, of course, a variety. Just the case differences seem to also be different in each clinic. Mostly at the FHCN, that's what Dr. Simpson mentioned, predominantly Hispanic, but mainly represent because that's the only county rheumatology referral clinic. So it might reflect the Fresno population. While in the faculty practice, where I do see my own patients, is most of quite a representative variety of all demographics in the Central Valley, in Fresno particularly.
Awesome. There's another question. Can or do you teach your patients skills in clinic to help manage their condition since the wait time to see a rheumatologist is so long?
Yes, that is my hopes. I've been speaking for Doctors Academy because I'm seeing it long term. While the counseling is so important, it's the time limited to see each patient. While in between, I've wanted to bridge that gap that there are resources like I've heard of Promotoras. Like, can someone check that they're not having side effects or they understood their medicines? Because these are biologics and immune suppressants that is not without risk. So the counseling is as much as possible. And I have been talking to my patients with, they have to also understand their condition. So it's the amount of time that I wish I could spend more, not only for their condition, there's psychosocial factors that may affect their quality of life when dealing with these chronic autoimmune conditions.
Totally. In the chat, everybody's very thankful for your presentation. There's some people who are considering rheumatology because you're very convincing.
So through summer, I'll have my contact information because definitely wherever you are, I'm open to reaching out and working with you in the career path, not only for rheumatology, but as a female. And my kids are grown, so I have my babies are my med school. No, I forgot. I have my 10-year-old. I have to still remember her. But yeah, my mom takes care of her.
That's awesome. Just to end at a better or fun note, what was your favorite Star Wars film and why?
Oh, that's episode 1. And my fascination is that how did they think of making episode 4, 5, 6 in my generation, 70s, 80s, and then episode 1, 2, and 3 in the 90s.
Yeah.
And then now it's Disney. So where Qui-Gon Jinn was, I testing my knowledge, but I use that. I have ANCA antibodies that I have mnemonics from Star Wars when I teach my residents.
That's
So that's
awesome.
a suspense primer for anyone who wants to reach out and rotate with me.
I love it. Thank you very much, Dr. Reyes. We will get your information to the participants next summer and did put a link for your information that people can reach out to you. So thank you for taking your time and giving this talk. We really do appreciate it.
Of course. Well, thank you.
Yeah.
Take care and stay safe, all of you.
Yes. All right, guys. Thank you for sticking around till the end. We appreciate it. I hope you learned a lot today. We will be back next week with 2 other great speakers. We're going to have Dr. McMillan and is it Dr.
Kraus.
Dr. Kraft, yes. And so we're going to have a adolescent psych, and then we're going to have a palliative care. So that's going to be pretty amazing. So we'll see you next week for sure.
For Mental Health Week, it's going to be great.